Thank you, Parveen. So next 8 minutes, I'll be giving you some tips of managing intraocular foreign body. It's not going further. Yeah. So nearly about 18 to 41% of the open globe injuries, they have intraocular foreign body. And majority of them, the entry wound is the cornea, or it can be through a limbus, or 25%, about 1/4 of them, it's through the sclera. And about 58 to 88% of them, the foreign body is localized in the vitreous. Very less than 10%, it's intralenticular, and about 10 to 15% it can be in the anterior chamber. It's very important to understand timing of removal of intraocular foreign body, and there have been multiple studies trying to compare whether we can remove it less than 24 hours versus more than 24 hours. And definitely there is a lot of evidence now that first 24 hours are very crucial. After 24 hours each day, the risk of intraocular infection increases by nearly 4-folds, meaning that primary repair along with foreign body is a good idea in majority of cases. However, if there is no expertise or if there is lack of instrumentations, you can delay it, but preferably if you are doing it, have a broad spectrum intravenous antibiotics. Intravitreal role, just assuming that there is infection, there are very less evidence for it today. So I'll just share an intraocular foreign body fight plan. Like first is recognize that there is a foreign body by history, unilateral uveitis, cataract, heterochromia, iris damage, presence of vitreous opacity or intraocular mass. Identify there may be other injuries like vital signs, they are stable, there may be a life-threatening injury along with it, and the intracranial injuries. The immediate care has been well documented and when spoken before, a good ocular history examination, diagnostic tests, check about the last oral feed, informed consent, systemic antibiotic, tetanus booster. Important is to put an eye shield, and in a chronic case, long-standing ERG if you are suspecting sidrosis or toxicity is suspected. So primary goal is a safe extraction of this foreign body, closure of the entry site, and prevention of endophthalmitis. The lens removal whenever necessary with or without intraocular lens, and vitrectomy for a posterior segment intraocular foreign body. And in long term, the major problem is inflammation and PVR, so prevention of modulation of inflammation, secondary surgery if required, especially because majority of them, it's the PVR which is responsible for failure of the surgery, and the major sinister, that is the amblyopia, especially in children, so that's very important to handle. Again, just reiterating the fact that if there is an open wound and there is a time of transport, better to put a rigid shield so that there is no further injury. Many times patient may be having nausea or vomiting, good idea to give anti-nausea medication because the vomiting can have more expulsion of the intraocular content. It's important to note the time of last full meal before the injury. From there, the anesthetist usually counts the 6 hours. I'll be sharing few videos of cases which will give us some idea how to manage these cases. So this was a gentleman, a young man with, can you just, a foreign body embedded on the inferior arcade and causing a sectoral branch retinal vein occlusion. So you can see the metallic foreign body and subsequent area having vein occlusion. So this is Pvd induction, posterior vitreous detachment. That's a very crucial step. Majority of them are young individuals and they don't have posterior vitreous detachment. So the first step is Pvd induction. Once Pvd is induced, vitrectomy is done. So you can see the vitreous strands are all attached to the foreign body. So that is taken care. All these strands are cut. You can see there is a capsule which is encapsulating this foreign body. So next step is trying to remove this capsule so that the foreign body becomes free. Once that is taken care, you can see the vein occlusion, all the hemorrhages in that quadrant. The foreign body has caused occlusion. It's a good idea to do laser around it first, because once we remove, there may be a heme which may prevent further laser. Later on, you cannot do an endo laser. And once endo laser is done, this is the intraocular magnet. So with the magnet, the foreign body is lifted. There are some strands which are attached, which are freed by the other hand with a light pipe. So this is important. In this step, sometimes there can be a bleed. So once bleed happens, doing laser would be difficult. So before removal, it's a good idea to laser. And once the foreign body is made free, this is the handshake technique. We extend the sclerotomy site. It's important to make a circumferential sclerotomy so that we can enlarge it and align the foreign body to so that it can come out through the port. And then a fluid gas air exchange, and further, in this case, gas was put. And this was the post-op outcome of this case. Sometimes you may have glass foreign body, and these foreign bodies, it's important to realize these are usually very fragile, even thin glass, or this case it was a thick glass. It's important to remove these from the limbus rather than from the sclerotomy sites, because it can break easily, and once it breaks and it becomes a powder, it becomes very difficult removing. So good idea to remove glass foreign body from the limbus rather than from a sclerotomy. It's important, especially those glasses like the photochromatic glasses and the dark glasses, they have halides, and they can incite a very severe reaction in the eye. This is actually a more anterior impacted foreign body, and we expected that we have to sacrifice the lens. So in this case, we went ahead doing a lensectomy first, and after doing lensectomy, just 1 minute, this is the last video. Do a vitrectomy, the anterior mid-vitrectomy, removing the blood in this area. The next step is the Pvd induction. You can see the posterior vitreous detachment. This is a very important step, and once Pvd is induced, we looked into the foreign body. It's pretty anterior. Again, the next step, as we told, we trim the capsule, do the laser around it, and tried removing this from inside. But we realized that this foreign body is very much embedded. So we just went in like a buckle, tried localizing it from outside, made a nick, and removed the foreign body from outside. So that's a very anterior foreign body. We can anticipate that we may not be able to remove it from the inside of the eye. This I'll just skip. It's from the iris, and here just from the visco. Important to remove it from the fibrous capsule, inject visco, and passively it will go through a 23 gauge needle. So you need not actually pull it, just inject the visco, pressure, increase the pressure in the anterior chamber, and the foreign body moves in the 23 gauge hub. So very high index of suspicion, early recognition, and intervention leads to very successful outcome in cases of intraocular foreign body. I would like to invite all of you to Ocular Trauma Con 2018. It's an annual meeting of Asia Pacific Ophthalmic Trauma Society, Ocular Trauma Society of India, and our annual event Shankanetralaya Retina Summit. So it's between 13th to 15th of July 2018. Those who are interested in, or those who are dealing with trauma, this would be a very good scientific feast for all of you. Thank you very much.